And so I walk, I move, I use my hands, I use my neck, I look around the place. And that is so important because my pain levels came down and I do not have flare-ups, which is very unusual with a serious neck injury not to have flare-ups. It's because, frankly, this stuff can work.
Today's episode of Better Thinking Podcast is with Randolph Sparks, clinical psychologist, and in my eyes, expert in pain management. We talk about chronic pain, phantom limbs, all sorts of things, and it's really good stuff. Also, if you're a clinician and interested in ACT training, acceptance and commitment therapy training, go to neshnikolic.com. You'll find a tab up the top, click on training, and you can get 8 CPD points just through watching the videos. There's about 49 videos and some content to read through as well, so I'm sure you'll enjoy that. Also, just another little reminder, if you enjoyed this podcast, please make sure that you click to subscribe. It would mean the world to me.
Okay, life can be crazy. You're feeling like you're sinking, just trying to find a meaning. It's time for better thinking, yeah, better thinking. Time to tune in. Let's go.
So today we've got Randolph Sparks, clinical psychologist, and in my eyes, expert in pain management. He's not only a great psychologist, but also a great friend of mine. So welcome, Randolph.
Thank you, Nesh. Great to be here, mate.
Obviously, I've called you on because I wanted to pick your brain and give everyone an opportunity to hear from you about pain management. Obviously, your world, a lot of what you do is chronic pain and obviously everything else, but it's something you've specialised for many years now. And I think when we first started working together, you were getting some excellent results, and I think it's probably only moved forward since then. So I'm not sure where to open up and where to start. It's such a big, broad topic. Maybe you can give us a little bit of an intro of how you got into it, maybe as a starting point, and then we'll kind of go from there.
Sure. I was a psychologist working on a mental health team. That was fun in Goulburn. And a friend working at a pain unit knew that I practiced what's called Vipassana meditation. Mm-hmm. And it hurts, that form of meditation. It really hurts. So she said, maybe you've got some skills for pain management. And I joined the pain management unit at the Canberra hospital, and off we went. Currently, I teach pain management in the clinical program at the ANU. And still doing it. I'm probably down to about 60% of my workload now is chronic pain. I like to mix it up a bit.
Talking about pain, I think you lectured me for a little while and were my tute. So you're still pushing out the pain for the students at ANU, are you?
I am, mate. I just want everyone to know that Nesh was an awesome student. I still remember the climbing on the desk episode.
Well, that was part of a good presentation.
It was.
Back in
It was
the day,
fantastic.
Right?
Yes,
and that was social psychology, I believe.
It was social psychology. I was lecturing then. Yes.
Yeah, so I was probably demonstrating, what it looks like to be psychotic or something. So you're doing lecturing. It's about 60% of your work that you're getting into practice at the moment.
Chronic pain is about 60%. Yeah. Lecturing's about 2%.
Sure. But still, important to, obviously I've got you on the show today because I think, what you do is awesome.
Thank you, Nesh. Yes. Apparently, around 1 in 5 adults experiences chronic pain, and they're pretty high numbers. And that means that most psychologists are going to be presented with people experiencing chronic pain, struggling to manage chronic pain.
1 in 5?
1 in 5, the research tells us, yeah.
I didn't realize it's that high. That's extraordinary. That's 20%. That's incredible.
And when we think about it, things like lower back pain, they are quite common. And I mean, many people are not constantly in pain,
sure,
but they may be experiencing what we call flare-up cycles. So things like back pain, neck pain may be okay for a lot of the time, but sometimes they really flare up, and that can result in what we call a flare-up, which is a massive increase in pain, a loss of movement, and all the suffering that goes with that.
Mm-hmm.
And in pain management, in the models I use, that's one of the main targets. We want to try and train out flare-ups wherever possible.
Do you see it occurring more with a particular population being the older you get, or is it people having injuries, car accidents? Where would you say sort of chronic pain comes from, or is it this sedentary lifestyle that we have, and the moment we start moving a little, we start breaking ourselves?
Look, I think it's a fair spread, actually. I see a lot of workplace injuries, motor vehicle accidents, and just general lifestyle kind of things. One day you pick something up the wrong way and then you've got back pain and it recurs sporadically. Can be all kinds of things. Also, some illnesses can result in chronic pain, things like diabetes, multiple sclerosis. These kind of illnesses can also leave someone really trying to manage and battling with constant and flare-up-y kind of pain.
Mm. Before we go into the, I suppose, pain that's very much related to, physical injury, someone's picked up a box in a awkward position and have done something to their back, probably quite a common occurrence. Would it be all right if we spoke about some of the more interesting, not interesting, more rarer sort of spaces around like phantom limbs or, well, in actual fact, I think you spoke to me about once upon a time, the immobilization sort of effect that someone holds their, let's say they've hurt their arm and they've held it that way, and that's gone out and caused more problems. Can you maybe tell us about obviously we've got the general pain, if I can call it, that's probably not appropriate, but the pain that comes from physical injury, and then there's other more complex pains that sort of show up?
Look, I see them all as interrelated and crossing over a lot. So basically, we might say chronic pain. One way to look at it is that chronic pain is the body's reaction to an acute injury. That is, I've just injured myself. I've just hurt myself. But the nervous system keeps reacting as if you've just hurt yourself. And then we've got chronic pain. So when we initially injure ourselves, we are hardwired to immobilize. And what I'm saying is if you break your arm, it really hurts. Now, if you immobilize it, you hold it still, your pain levels will go down pretty quickly. Now, you haven't been to the doctor yet. You've just immobilized it. Your pain levels come down. And so that's a really important and helpful thing we do when we have an acute injury. So as soon as we injure ourselves, we immobilize, we stop moving, and that's the right thing to do. So when we have chronic pain...
And that's to avoid further injury, I'm assuming, or to avoid greater pain. The body, the whole organism just says, stop.
Stop.
Don't go out and move that anymore.
Yes.
There's been an injury. It needs to be looked after.
Yeah.
Okay.
And also, again, a crossover where a pain is actually a danger signal. And so, again, when we injure ourselves like that, we're also in danger. And so we're also immobilizing to stay safe. So there's a crossover there. Kind of a freeze effect, but also just stop. Stop what you're doing. That's dangerous. Take your hand off the hot plate of the barbecue. That's dangerous. So we immobilize. And that's the trouble is with chronic pain, we're still getting the underlying injury or whatever it is triggers up a pain signal, and then our nervous system reacts as if we've just injured ourselves. So we immobilize again. And a flare-up is a big immobilizing.
Okay.
So that means, say, with a lower back pain flare-up, you can't move your lower back. But it also means that you can't do much at all, and you might often end up in bed for a week or two. Now, again, with chronic pain, this isn't actually helpful because we haven't just injured ourselves. It hurts, and there may be a serious injury underneath, but it's stable. It hasn't just happened.
So initially we immobilize, and that's quite useful and helpful.
Mm-hmm.
But then we kind of, we go to the doctor, we seek treatment, so on and so forth, and some weeks or months or potentially years go by. There's a flare up. Does that flare up come from somewhere from your experience, or can it be, I've injured my shoulder and so I've overdone, I've overworked it, or I've taken another, or I've, gone out and used my arm to break a fall or something, and it's kind of triggered it a little bit, or does it just flare up in and of its own accord?
There are various triggers, we believe. And so obviously, yes, as you said, Nesh, overdoing it with the part of the body that has an injury will again trigger up that pain response. And again, the nervous system says, uh-oh, I just injured myself. But it's the old injury. It's not a new injury. We do find that people can have spontaneous flare-ups, and that is there's no clear trigger for this. Now, it may actually be that they pinched a nerve. So a lot of chronic pain is neck pain and back pain. And that often means that we've got what's called a bulged disc. And that's the disc, the squishy bit between the vertebrae. And many of us have bulged discs. If it happens to pinch a nerve, we can get a shot of pain through the system there. And that can go into the leg, it can go into the arm, it can go anywhere that nerve's going to be traveling to. And again, we can then experience a flare-up of that. The more random flare-ups, we believe are that the associated neural pathways have become quite sensitized. And that's because they've been triggered a number of times and there's a lot of danger around them. Even consider things like, we know at a very deep level the importance of some parts of the body. So if you hurt your little finger, hey, it's no big deal. We can handle a bit of pain there. We know we've got 9 other fingers. But neck, back, head, hey, these are really important. And so when we get
one off.
Yes. When we get pain in these areas, big danger signals there. We know these are important parts of the body. And so we're more likely to have an enhanced danger response, which then overlaps with the pain signal.
And it's interesting, just thinking out aloud, those areas are also incredibly crucial where we've got organs in those certain places that need to be intact or protected, particularly in the spine. With the spinal cord, all our nerves running up and down and so on. They're vital places. So maybe there's something organically there that's more protective than, as you say, our little finger.
Yes, there's a hierarchy of danger, a hierarchy of importance. Having said that, these things, if you can hear this, they're very strong.
Yeah.
And that's the thing, our spines, our necks, our backs, our heads are actually very strong.
Sure.
But that doesn't stop us knowing how important they are.
Yeah.
And so again, that's why we say that the injuries are quite often stable but painful, and that leads us into these cycles. A lot of this immobilization understanding came from a brilliant guy named V.S. Ramachandran, and he worked a lot on phantom limb pain, which you mentioned earlier. And as with many geniuses, his discoveries were ridiculously simple. So when we hear it, we're going, well, of course, but we didn't know it, And I always think with these things, it's like, when did we put people on the moon? 1969, pretty good. When did we think of putting wheels on suitcases? Not till the 1990s. Now, it would appear terribly obvious to us now, wouldn't it? But back in the 70s and 80s, we were carrying suitcases with handles because no one had really thought of this.
Isn't that incredible?
It is incredible. And so what V.S. Ramachandran realized...
And that was a genius moment as well, right?
Genius. I just wish it was me. One of those discoveries.
Randolph Sparks, the man who put wheels on luggage.
Oh, man. And so many of these just strokes of genius are so simple.
Yeah.
Really. Right. And so V.S. Ramachandran, his stroke of genius was phantom limb pain means that you've lost a limb. But the person experiences the pain in that limb as if it's there. Now, we can look at the sensory motor cortex in the brain where the body part is still represented. We can see there's pain going on. So the pain is real, but the limb is not there. And so his breakthrough was he said, look, the problem is not that we've lost the limb. It's not that we've amputated the limb. Okay, well, what is it then? He said, it's not moving. Genius.
Because it's interesting because someone who's lost, let's say, their arm and they've got pain in their hand, they're feeling as though you and I have pain in our hand. And so we can visually see our hand and this pain coming from, I might say, oh, it's my thumb that's hurting. And so there's this extreme pain from my thumb, although the thumb is not there.
Yes.
Yeah, fascinating.
It's a fascinating thing, yes. And very painful and very real. That's the thing.
What's as real as, it's not like, oh, it's in your head. It's as real as if it's in your hand.
Yes.
Yes.
And we've struggled with treatment for phantom limb pain. Like, say you've lost your hand, massage to that hand is going to be ineffective as a treatment.
Sure.
We've got good evidence for this.
That would look awfully strange as well. We're going to go into the lab now and massage your hand. Do you want to come or you can stay at home?
So, we've been limited. But what he found was that the body is sending signals through the nervous system to the brain. And the information that our body sends to our brain, one of the main sources is actually movement. And we can try this at home. So if you sit perfectly still, don't tense, don't move, can you perfectly feel your left knee? Now, probably not. Fuzzy at best. But if you move it, suddenly it's there. We can feel it clearly. And so when we remove the limb or when we immobilize a part of our body, we're not sending movement signals. And so what this means is with something like lower back pain, people are not moving the lower back.
Hence why we immobilize to reduce the pain. So the moment we stop moving, that feeling goes fuzzy, so to speak.
Yep. And that means that if we keep immobilizing the lower back, so we're walking around, we think we're walking perfectly normally, we're not moving our lower back. And we stand in what we call protective positions. We sit a certain way, stand a certain way, walk a certain way. And
is that what people call like compensating, where you might tighten muscles around it? You can't necessarily see it yourself. You need probably a trained expert's eye to go and say, look what you're doing there, or a camera to help you see it. But we're tensing or we're holding our body, or our gait slightly changes, even though it might feel natural to us. It's different from what we used to.
Yeah. It's protective. We're trying to stay safe. And so when we hold ourselves still, we're also sending signals that there must be something wrong. Why would I be holding this still if there wasn't something wrong? Now, if something's wrong, then pain is appropriate.
Yeah.
Okay, now again, don't try this at home, kids. But I suspect that if you put your arm in a sling for a month, it would start hurting. Because you're not moving it. You're saying something is wrong. Now,
people talk about this in hospitals, don't they? So I've had a long hospital stay. I've been in bed and I'm lying there and, for example, my back's starting to hurt.
Yep. And in fact, in hospitals these days with this new knowledge, if you have an operation, they make you get up very quickly and start moving. Even with serious operations, get up, move around, If back in the day, we'd leave people in their hospital bed for 3 to 6 weeks after an operation.
And it looks normal, doesn't it? It's like they've just had a big, operation, leave them there, and that kind of really satisfies the loved ones of that family member. And these days, they're asked to kind of get up, move, even when they're doing, serious knee ops and all sorts of stuff.
Yes.
And, we've kind of changed our take on it where, we would previously say, the surgeons are crazy. Why are they getting my loved one to move? Because it hurts. They shouldn't be moving, when in actual fact, you're saying the data is obviously very different these days and it's based on these findings.
We need to move. We need to move. If you immobilize for too long, you change the information flow through the neural pathways. And that's what's getting us in trouble. And so for pain management, we have to move.
So initially we've got the somewhat like freeze response in terms of immobilize, stop moving it. But in chronic pain, we're kind of saying we've gone through the immobilization phase. We've got to start moving it. I'm imagining myself as the person in pain. Yep. I would be very resistant to that, wouldn't I?
Absolutely.
I'd be saying, Randolph, you're crazy. Like, every time I move, you want me to have more pain.
Yes.
It hurts that I can't, right? It's too much for me. I can't bear anymore, right?
Yes. And so start moving a little bit. Just start moving a little bit. Something like, again, I'll use lower back because it's so common. Start moving your hips a little bit. They won't want to, but if you can just start wiggling a little bit, then you're teaching your nervous system it's actually safe to move. Now, don't move so much that you're going to overdo it. Move a little bit until your system gets used to it. Move a bit more, and then try and move normally. Now, again, one way to look at it is we're trying to convince our nervous system that nothing is wrong, even if we know there is something wrong. What choice do we have? If we immobilize, we can stay in pain, and we can stay in pain cycles. So regardless of the injury, now again, do seek medical advice. I'm a psychologist. But for chronic injuries, we say you've got to move and normalize as much as possible so that your nervous system just says, it's okay, I'm moving. And you're getting those movement signals through the nervous system, which says, I'm here. Here I am. We have weird and not wonderful, but weird and horrible pain conditions. One is called complex regional pain syndrome. And this is a truly awful pain situation. And it often happens to one limb. So say you have a minor fracture in your hand. That hand, a year later may be swollen and purple and doesn't move and is incredibly painful.
As in, you had the injury, it's kind of healed.
Yes.
And then a year later, we have this kind of flare up, if you will.
And it stays. This one stays. Now, with this one, this is a fascinating but painful condition. A person with complex regional pain syndrome often will not know where their limb is. They can hold their hand above their head. They might think it's down by their side.
What?
It's a truly weird thing. And that is that connection between that limb and the brain is not really functioning. And so they've lost movement. The system forgets where it is.
That's very similar to that gentleman. I do apologize, can't remember his name. The genius who was working with phantom limbs, and he recognized that the limb, the connection between the brain and the limb, what was, having this issue around, I suppose, not movement, it was immobile.
Yes.
And I think if you don't know where your arm is, it's going to feel like it's immobile.
Yes. Nesh, that's why you were such a great student, mate. That's awesome. Yes, absolutely. And actually, we can treat the two the same. So V.S. Ramachandran, what he found was that there's various ways to get these signals through. So with phantom limb pain, he started using mirrors. And so if you've had one hand amputated and you have phantom limb pain in it, you can set yourself up with a mirror and put your other hand in the mirror so that it looks, the wonderful mirror box.
Please describe what that is so that everyone listening can understand.
Moments of genius and simplicity. The mirror box was the breakthrough, and it's a box with a mirror on it. Isn't that great? And so,
how does it work?
Okay, so we simply reflect the limb that is there so it looks like the missing limb. We move it around, and that sends movement signals to the sensorimotor cortex.
So you look at the mirror, and you move the hand that you do have, and it looks as though you have your other hand. And so that in and of itself sends signals from the limb that's not there.
Yes.
To your brain.
Correct.
Brilliant.
Absolutely brilliant. I've got one. I can bring it over one day.
Oh, maybe we can go out and take some photos of it.
Yeah. And I often have my clients try a little experiment with it, which is simply to put one hand behind the mirror, one hand in front of the mirror, move them around exactly the same way. and hold still, and then just move the hand that's obscured by the mirror, behind the mirror. And most people will say, whoa, that feels really weird. and that's because the brain has connected to the image. And when you move your real limb, it feels wrong. It's just brilliant.
Isn't that incredible?
Yes. And so with phantom limb pain, that's how we started treating people much more effectively. And also now, if you get a prosthetic limb, it looks more realistic.
Oh,
really?
That's a game changer, isn't it?
It's a game changer. And people say, oh, I think I can feel it. Now, they can't. It's a prosthetic limb, but it looks like one. It moves like one.
They can, because their brain is going out and saying, I can feel my thumb and index finger moving.
Yep.
And I can feel it as though I feel my other hand.
Yes.
The brain makes no distinction, right? I mean, if someone pulled a gun on us, even if it was plastic, we would feel that it's a metal one and would give them our wallets or whatever they want. We interpret it as being the real thing and the more lifelike.
Yes.
I mean, if they put little hairs on it and all that sort of stuff, the more it looks like mine.
Yeah.
Oh, wow.
Or nice nail polish like your brother's string.
String, if you can put a photo as well for the YouTube viewers of your hands with nail polish.
And as you can imagine, the old pirate hook just didn't do the trick.
Looks good.
Looks super cool, but you're more likely, in my opinion, you're more likely to have phantom limb pain. And so, again, movement is so important. And when we see this connection, we really got to work on it. And, we've also got to work with chronic pain on reducing danger in the nervous system as well, because pain is danger. And so things like relaxation exercises are really important. Your breathing exercises, progressive muscle relaxation, all those kind of cool things, just to get our danger system down a little bit.
So they work on a level of, I suppose, reducing our sensitivity. If we're a little bit calmer, if we're a little bit more relaxed, our heart rate's down, we're less in this kind of apprehensive state or danger state, hypervigilant state.
Yes.
So we've kind of reduced that, and that just has a general reduction in maybe how much signaling we recognize, or even how much signaling we create.
Or that we can interpret the signal as a signal and not as a new injury.
Yes.
And that's the trick. So we can still pinch a nerve. We can still get a twang. But if we don't perceive that as dangerous, we may not continue to have pain with that for a while. It may hurt at the time, of course, because we may have just pinched a nerve. But that's so important.
In chronic pain, wait. In chronic pain, when someone gets a twinge, the interpretation is another injury. I know you've kind of mentioned this, but the penny hasn't dropped. They don't necessarily feel it as though it's a symptom of the injury that they have. And so each time they're going back to immobilization, rather than saying, oh, that's because I hit my knee, 6 months ago, and that's why it's hurting. They kind of go, oh, it's almost like I've hit my knee again.
Yes.
And it's a new injury.
Yes. And this may not be conscious at all. It's something in the nervous system saying, you just hurt yourself. Now, you just hurt yourself 100 times in the same spot.
And that makes sense because rationally what we're thinking and what we experience two different things. We can all say rational things, but we're feeling something completely different. So,
But also rationally, if I break my arm, I know I'll have use of it and unlikely to be in pain in around 4 to 6 weeks. So with many injuries, we can predict that we will be out of this situation. You cut your little finger, it's going to stop hurting in a couple of days.
So the interpretation reduces your anticipation of it being a lifelong
Yes.
change for you?
So what happens if this pain just continues? What happens if you have a nerve impingement in your spine and it just keeps pinching those nerves? Then you're not able to say, this is going to end in 6 weeks. You cannot predict where it's terrifying. And there you go. There's the word. Terrifying, danger systems are up. Well, now we're going to immobilize.
Yeah. I'm just thinking even like a minor, injury to your little finger, if it felt like that was going to be forever, that would be terrifying, because you'd be saying, how do I now live with walking around with my finger throbbing?
Yes.
Because it's consuming me at the moment. I've just gone out and squashed it in a door. This is awful. And there's not going to be an end to it.
Yes.
Wow.
I'm currently working with a gentleman who hurt his finger. And it was a bad injury. Sure. He now has complex regional pain syndrome with that finger. And that was what happened. It did not stop hurting as it was supposed to. Now, it was complex medically, but now it's a whole different ball game, because it's years down the track and he still can't use that finger. He still holds it perfectly still. And it still hurts. But it hurts so much to move that it's a big job to try and get the ball rolling. So we have various techniques. Now, one technique for chronic pain to try and get us started. Now, again, with complex regional pain syndrome, this is a really big ask because of the intense levels of pain. But often what we'll do is what's called desensitization to pain. And that is it's like you have a phobia to dogs. Okay. Now, when we're treating a phobia to dogs as psychologists, we're getting people just to get used to it, to habituate to it, to desensitize to it. And that is by sitting through it. Okay. So we can do the same with pain. And that is when we're treating a dog phobia, we're not trying to change dogs. That's going to be a big job, isn't it? We're trying to change our reaction to dogs, our reaction to a photo of a dog. Even if we have a dog phobia, we will experience anxiety with a picture of a dog if we have a dog phobia. So with pain, we use the same kind of thing.
And we gradually introduce it to that, like almost like build a hierarchy of what someone's willing to start off with, which might be, I'll look at a photo.
Yep.
And that photo might be, even from a meter away. So, because it's not, and then it might move to holding the photo.
Correct.
Might be hearing the noise of a bark, for example, or watching a video. Yep. All the way until one day,
we're patting a dog.
We would hope to be patting a dog.
Yeah. Now, that actual anxiety, if we make no attempt to escape from it, will come back down. Now, in an experimental condition, okay, that means we're controlling for all kinds of things, that takes around 7 minutes. So we look at the picture of the dog, our anxiety goes up. And if we don't try to escape from it, it comes back down. It has to. Anxiety always comes down.
I never knew it was 7 minutes.
It's around 7 minutes in an experimental condition. Sure. And so we know this comes down. And so we do the same with pain. And that is, you hold your attention on your pain. Now, realizing, of course, you can't injure yourself by doing this. You're not doing anything. But as you hold your attention on your pain, your anxiety is going to go up. Now, if you just gently hold it there, we're not thinking about it.
We're
simply
like
observing.
Paying attention to it.
Yes.
Like kind of observing it with curiosity.
Correct.
Sure.
Yes. And as we do, our anxiety goes up and then it comes back down. Now, I do this in session with my clients, and I've got to admit, once or twice, I've got to, 6 minutes, 59 seconds. I'm thinking, is this ever going to work? And it does.
Sure.
The anxiety comes back down. I'm saying, I'm not anxious. And so the more times we do that. Yes, indeed. We're not a precise science here in psychology. But generally what that means is the more often we can just hold our attention on that feared thing, which is our pain, the less fearful we are of it. So now we can move it. So now we can observe it. People who practice desensitization report back to me things like, tell you what, now when my pain wakes me at night, I focus on it and go back to sleep. Now, early sessions, that's crazy talk. Okay. Once we've done a bunch of stuff and we practice this, that actually works. Sometimes I feel that pain. Again, it's like say in my back or my neck. I feel that pain. I go straight to it. It moves, or I can't find it.
Yeah.
It changes because I'm not scared of this thing. And if I'm not scared of it, it's
moves.
lost its power.
Yes.
And that's what we're doing. We need to reduce the importance, the danger of those signals, regardless of our injury. Often the treatment is worse than the injury.
Now, anxiety does a similar thing in terms of when you focus on it, it tends to kind of move.
Mm-hmm.
And for example, in, let's say, obsessive compulsive sort of difficulties, we might find the anxiety forms somewhere else. So if someone's, afraid of something awful happening to a loved one if they don't turn a switch on and off 7 times as they walk into the room, if you desensitize to that, they might find that if they don't go out and, let's say, touch the wall twice as they put their hand in to walk into the room, the same awful thing might happen. Does that happen at all with pain where the pain can move, let's say, for example, from the hand to the shoulder or to the elbow or something like that, or even to another part of the body?
Yes. Wow. Now, generally, we're doing desensitization. No.
Okay.
That is not the aim.
That. Yes.
If we're just experiencing chronic pain, yes. Pain can move. Pain can spread. It can go from you have one shoulder that's painful, the other shoulder may get painful. Now, we're not entirely sure of why this happens. One can be overused.
Is it usually the same area? For example, if it's your shoulder to shoulder, elbow to elbow?
Often it is. And that can be simply because you're favoring the other side because you're immobilizing the injured one. But we also believe it can be at the level of the sensorimotor cortex, and that is that in the brain, these parts are right next to each other. And so you may have some leakage across there. So again, normalize, get friendly, get used to your pain sensations.
Sure.
Until they're not pain, they may just be sensations.
I interrupted. Well, going back to the graded exposure type or the desensitization. What do you do after that as you get more and more closer to being able to, I think you call it a wiggle or move or mobilize? Yep. You do that on a greater level over time?
Yes, we want to restore normal movement. Just because you have a lower back injury doesn't mean you can't walk normally. Now, maybe in your instance that's the case if you've had a fusion or there's some physical reason, but in most cases we want to walk normally. We want to move our arms normally. We want to look around normally. So our aim is to normalize our movement and normalize our lives. And because, again, when we have chronic pain, our lives are no longer normal.
I can just imagine so many listeners who live with chronic pain just going, that's just impossible. Like, not for me. My neck has been stuffed since that motor vehicle accident. How could that ever possibly be? I've been walking like this for years. I imagine it's hard for someone to hear.
Yeah.
I know that every instance is different, but I'm still hearing that there would generally be, and obviously everyone has to go out and consult with their own medical team and the like, but there's an understanding of we've got to move. Like even if you feel that it's impossible
you got to move
to do so, we've still got to start gently doing that, knowing that it's going to get worse before it gets better.
Most likely, but not necessarily. If we start with very small movements, they may not hurt at all. Yeah. And we just get the nerve, like looking at the photo of the dog.
Yeah.
We're just moving that little bit, and since the anxiety goes down with a little bit, we can move a bit more. Now, bear in mind, everyone is different, and with chronic pain, we may need to find a balance, and that is your injury may inhibit you doing certain things. You may not be able to do as much as you did. So we've always got to make choices as we go. Now, choice is the first thing we lose with chronic pain. We did not choose to injure ourselves. And choice is a direct modulator of pain. That is, if we choose to do something, we can withstand more pain. Now, if I want to do 20 push-ups, it will hurt. I know it'll hurt, but I can do 20 push-ups because I chose to.
Yeah. Choice with pain. There was a bucket with ice experiment.
Yes, indeed.
Do you know that one well? Or
Yes.
Maybe you can talk us through that, because I know the fumbling way through. I don't know the whole.
Well, let's say I'm a scientist, and I'd like to see how long I can hold my hand in a bucket of ice. Okay, I'm a scientist. I'm doing this objectively. I put my hand in this bucket of ice, and after about 25 or 30 seconds, I will have to remove my hand. Now, you on the other hand, Nesh, you fell into a frozen lake as a child. No way you want to put your hand in that bucket of ice. What if I make you? How long will it take you to reach that point you must remove your hand? Well, about 5 seconds.
Mm.
And that means choice is playing a part here. Now, again, we want to choose, but we have to be realistic. That is, if you have an injury to your neck, to your back, wherever it is, it may not function the way it used to. There may be limits on what we can do, and we don't want to be overdoing, because that will give us a flare-up also. So it's a balance. So these are all theories, and these all work, but we must find our own balance. Now, I may tell you a little bit about my personal story.
Absolutely.
So some years ago, I had 2 discs in my neck's collapse. Okay, extremely painful, really painful. And now, I shouldn't say this, but I'm a guy, and we're not good at this stuff. So the main symptom was extreme left arm pain. It was a neck injury. Again, it's pinching the nerve into the left arm. Now, I thought, well, I'm over 50, probably having a heart attack. Now, when I was still alive a week later, I thought, maybe it's not a heart attack. I better go to the doctor. We're all humans, even if we're psychologists. We're all stupid sometimes, okay? And it turned out I had 2, very damaged discs.
First they raced you over to check your heart, and when they excluded that, oh gosh.
Oops. And so what that means to me is initially, okay, so much pain, even as a pain psychologist, I went with the medical model, of course, huge amounts of pain and immobilization. I was on medications, I was getting massage, I was seeing the physio. I went to the surgeon who said, you need a 2-level disc fusion. Now that means that they remove those 2 discs and then they lock together those 3 vertebrae forever. They'll never move again. Now, what that does is that frees up the nerves. Now, at that point, I thought, I don't want to do that. My models say if I never move my neck again, I may never get out of this. And so,
and I'm not suggesting that for lots of people that wouldn't be appropriate.
Absolutely.
But we're also trying to put in the context that the moment you fuse it, this way I'm reading it, the moment you fuse it, you're now actually creating immobilization.
Yes.
And that potentially has.
Or I work with people with fusions. We just got to learn to move.
Yeah.
You just train yourself to move again.
Sure.
Now, again, my GP reminds me often, he said, you start dropping things, we're going back to the surgeon. I'm like, okay, fair enough. But at this stage, I have full use.
Physically dropping things.
Yes.
Okay.
So if my injury has progressed to the stage where I'm losing use of my limb, I will probably need surgery. But at this stage, I can use my hand, I can use my arm, I have pain. Now, I went to the surgeon, I said, okay, here are my 3 favorite things. I like mountain bike riding, whitewater kayaking, and playing my guitar. And he said, well, you better find some new hobbies.
Lucky because none of those use your arms.
yeah. Now, to be honest, I can't really whitewater kayak or mountain bike the same anymore.
Sure.
Because that jarring is going to crush those discs. So that's a limitation now. But I can walk normally. I can move my arms normally.
You're saying you can't do it the same, or you can't do it at all?
Look, I can't do it the same.
Sure.
Whitewater kayaking, I've recently discovered inflatable whitewater kayak. So when you go off a drop and land on a rock, it's a softer landing. That might help.
Okay.
I strum a nylon string guitar now instead of a steel string guitar because that takes more strength with my hand for the steel strings. Mountain biking, more gentle. I'm not going to do the fall on your head kind of, stuff I used to do. Look, maybe that was part of the problem. Always wear a helmet, kids. So, but it means we may have limitations if we have an injury, but we still want to get as much as we can. And so I walk, I move, I use my hands, I use my neck, I look around the place. And that is so important because my pain levels came down and I do not have flare-ups, which is very unusual with a serious neck injury not to have flare-ups. It's because, frankly, this stuff can work.
How did you get there in terms of you elected not to go down the surgery route and you started to
Yes, I started to move. I started to walk to work and back every day. And in walking, I would move my arms normally, not hold my arms still because it hurt. I would look around as I walked, just like normal.
Previously, you wouldn't swing your arms.
No.
Because you'd immobilize. You didn't know that until you...
Yeah. And look, to be perfectly honest, I was explaining this model to a client recently and I'm drawing all this up on the whiteboard and my left arm is in a sling position. I'm like, wow, move you arm, So again, this is not conscious that when we have pain in an area, we immobilize. So my left arm was hurting and it put itself into an immobilized position automatically. I just have to notice, pay attention to it, quick desensitization, there it is, move it normally.
Isn't that incredible?
And that's the thing, this is not in your head. I have all the training, I teach this, I use it, but my left arm will still immobilize itself because it hurts. I got to keep reminding it and myself, there's nothing wrong with my left arm. I have a pinched nerve in my neck that makes my arm hurt sometimes.
Yeah.
So again, we've got to find these balances and
it drives me mad when I hear, it's in your head. Just places all blame on someone and kind of says, it's in your head. You just need to go out and, think differently. It's like, that's just absurd. We're blaming someone who, has had a serious injury or they're in serious chronic pain. And we've got to go out and support them in being able to live life with pain.
Yes.
As you clearly do, but start to pay attention to it and not necessarily try.
Not in a scared way, not with fear.
Yes, not with fear.
Yes, that's the trick of it. That's the
and
trick.
How long did it take for you? I know every case is different, but for you?
With my neck, probably around 12 months to not have any kind of flare-ups and have full movement again. That was a lot of work, and that's the thing. Yeah, it's not in your head. Pain is real, and it actually takes some extra effort here to normalize. Anyone with chronic pain listening here will know that, to go to the shop takes more effort than it used to. To get out of bed takes more effort than it used to. When you're carrying pain, you're expending energy. And that's just how it is. And so when we're doing pain management, we've got to be patient and we've got to be flexible. And again, what I present are models. I present, ways of looking at these and strategies to use, but we must adapt them for ourselves. How much you move, when you move, what activities you engage in. Use your judgment. No two injuries are the same, but I would say the same approach, whether you've got obviously two collapsed discs, whether a scan doesn't show what's wrong, you use the same approach, and that is down-regulate the danger of this pain and get your movement back and get your activities back. If you've got the same pain 5 years later, your injury hasn't likely got worse. You can check, have a look, and get a scan or whatever. But if it hasn't got worse, we've just got to get the pain down. We've got to get the activity up, the danger down. The signals are still going to be there. But again, if our nervous system is not scared of them, again, this is not our head, this is not us. Our nervous system is not scared of those signals, those sensations. We can get our function back and our quality of life back.
it sounds like the harder, not harder, my apologies. I imagine it'll be incredibly challenging when a client doesn't have a scan that goes out and says, this is what's wrong. It's just, I have pain in my back. And we had a look and nothing's wrong with my back.
Yeah.
And there's this kind of assumption that if we can't see it or if there isn't a scan that demonstrates it, it therefore doesn't, it's not there and therefore it's in your head.
Correct.
Versus going out and saying, no, it's not in my head. Clearly, pain's coming from somewhere. Obviously, I can feel that region. Why might be unknown.
Yep.
But we still use the same methodology, whether I've had a fall or I haven't had a fall.
Correct.
Move it.
Again, personal example, I had a CT scan on my neck and the radiologist said, oh, mate, you must be in terrible pain in your right arm. I said, no, terrible pain in my left arm. And he said, but the scan shows terrible pain in your right arm. I'm like, well, the arm begs to differ. That was a CT scan. I had an MRI and we could see, okay, there's nerve impingement in the left arm.
Did it change after the MRI? No, you're right.
Well, we got to be careful of these things. Now, I'm going to get a little political here too, and that is that, and this is how doctors and scientists, we can get it wrong sometimes. So there was a study some time ago, and they took MRI scans of random people's spines. And what they found was that many people have abnormalities. They may have bulged discs. They may have nerve impingement. Many people are unaware of this, and so they're not experiencing pain. Okay,
with
so that means
discs and impingement.
Yes. So that's telling us, okay, if we never knew, we might not feel the pain. And people have injured themselves and not known it. There are always war stories. People don't realize they've got a bullet in them because they didn't know they got shot. It's extraordinary, but these stories are out there. So that study, in my opinion, has been misused. And many health professionals will say, well, you shouldn't get an MRI scan because you might see all this damage you didn't know you had, and now you'll be in more pain.
Okay.
Now, what that means is if you've been in a car accident and you've hurt your neck, they may be saying, no, don't get a scan. That might make it worse. Now, rest assured, MRI scans do not injure us. They do not cause pain. Oh, they're not pleasant. I can assure you they're not a pleasant experience, but they're not injuring us.
Get me out of here.
Anyone who's had one, anyone who's had one will know they're not fun. But they're not injuring us, and that's the thing. So we can be refused by an insurer or someone to have a scan that may actually illuminate the problem. Now, again, we've just got to use our judgment and understand what we're dealing with. I personally think scans are very useful. I'm glad I got a scan. It's horrible. I look at it. It looks like it hurts. But that's okay. As I said to my doctor, look, I've convinced my nervous system that nothing's wrong when I know full well it is. I've seen my scans. So the scans don't necessarily...
Your relationship with pain has obviously changed.
Absolutely.
So in seeing a scan, if you view it in a way where your relationship is not one of fear, we might go and say, well, there's a bulge, but that's okay.
Yeah, that's what I'm dealing with.
Yep, it might go out and let me know why I'm feeling the pain.
Yep.
But in actual fact, I might find another bulge that's much lower down that I don't feel. Let's not be afraid of it because I could potentially start to feel that if I start monitoring in that area.
Yes.
Or I might be in such fear that I start to isolate.
You got it.
And
I start to immobilize, exactly. And now we're in trouble. So again, nothing's 100% here. Nothing is black and white here.
Yeah. Scans
can be unhelpful. Scans can be helpful. We don't just say no scans because occasionally they're unhelpful.
Sure.
So, as a person, who's experiencing pain, you need to make your decisions. And again, remembering that choice is a huge modulator of pain. And so when we're not able to make choices, our pain can go up. So try and make your choices. Make them within your limits. I choose to walk to work. Okay. I choose not to, jump my mountain bike over huge jumps onto rocks anymore. Okay. I choose not to do that. It's no longer a loss to me. That's where we have to shift this around. With chronic pain, we can experience a lot of loss, and we have to transform that. We can still make choices about what we do, what we don't do, how we move ourselves, how we manage our lives.
Moving into choice, obviously we've been talking about chronic pain that's predominantly come from injury. For a lot of us, our sedentary lifestyles have brought about, the immobilization of our bodies. I'm like everyone else as I've aged, and certainly, probably since the kids have come along as well, I can feel a whole lot more pain in my body. And it's kind of like everywhere, my knee, my arms, my back. And obviously I have a very sedentary lifestyle. If you kind of look at it, I'm in bed, I wake, there's a good, 6 hours of lying down, maybe wake up once or twice to check on the kiddies. But I'll go from there into a car into the office. I'm sitting in my consulting chair for most of the day or at the desk. I'll then go back into the car, back at home. And, if I'm exhausted, other than a little bit of a cleanup here or there, helping out with, setting the table or whatever it might be, putting the kids to bed, then I'm back on the couch and I'm back into bed. Sedentary lifestyle. What would you recommend would be just a little bit of a guide for, the air quotes, healthy person? What should we start doing to be, more mobile to hopefully protect us a little bit from the potential of pain, and maybe pain growing into, more frequent pain?
Just move, and exercise. Now, exercise has all kinds of benefits. We've got good evidence now that exercise protects us, buffers us, and helps us treat depression. So exercise is really important. And again, choose.
How did you know?
And again, choose. If the exercise you're doing you hate, okay, you're not going to be present, and you're going to get exhausted, and you might injure yourself. While the exercise you love, you like, you're present, you're aware, it's going to help you get fit and increase your health. So again, make choices. So for some of us, we don't like gyms. Well, then gyms may not ultimately be that helpful to us if we're pretending we're not there, so we're not doing our exercises properly. So
does it get down to that nth degree where if you're not enjoying something, that could potentially in and of itself pose as a bit of a threat, and then the bit of a protective model comes in, and so you might tighten muscles a little bit differently than if you were enjoying something, you might be more relaxed. Does it kind of work at that level?
I would say so, and I would also say at the level of attention. What are we paying attention to? When we're doing something we enjoy, we're paying attention to that activity. When we're doing something we don't enjoy, we might be distracting ourselves. Yeah. So if you're running and you hate running, are you watching where you're going? You might step in a hole, Kind
of like when going to the snow, you might have a wonderful day, and you're skiing or snowboarding for up until lunch, and then you start fatiguing, and at some point you're like, I'm not finding this enjoyable anymore. I want to get the most out of the day because I've spent all this money to get to the snow, et cetera, et cetera. But you're not actually having fun. You're just doing, one sort of a slope after another, and you're fatiguing, and you're more prone, obviously physically because you're fatiguing, but you're more prone because you're not concentrating, you're not enjoying it. You're kind of, maybe not miserably, but maybe close to it, going down, without any pleasure or joy.
And making unforced errors.
Yeah, plenty.
And that's the trick, isn't it? It's if we're not enjoying it, if we're somewhere else, we can make errors. While we're enjoying it, we're present, we're less likely to make errors because we're more synchronized.
Because I imagine if someone wasn't skiing all day, but they were getting to the slopes and then they got their first opportunity to get onto the slopes, because that enjoyment level would mean they're more present even though they're fatigued. And so they'd probably be less likely to make those errors, unforced errors, than if they weren't enjoying it after a long day. Yeah.
So movement exercise, I recommend walking to most people. Walking is the most natural exercise we can do. Humans were not actually designed to go to the gym or to, run marathons. We're designed to walk. Yeah. We're designed to walk. And so when we're walking, it's a great vehicle for normalizing movement. You swing your arms normally. You move your hips normally. You move your head and look around normally. And it's a great vehicle for normalizing movement regardless of injury.
Yeah. I never thought of it that way. It's every photo of a human is like them standing, we've seen those ones with the monkey moving, morphing into obviously human, and it just starts to walk. And then
we're walking.
We're walking. That's what we do. As you walk, you might tie your shoelaces or grab something out of your backpack or look around. There's a bird singing. You're kind of just moving as you would in any other situation. We all do it. We just don't do it enough.
Yes.
Is what you're saying.
And look, I'm going to go out on a little tangent here. I also encourage people who've experienced trauma, who are anxious, to walk normally, to look around. So often when people have experienced some kind of trauma, they will walk looking down. And that's to try and stay safe again. That's an immobilization, is trying to stay safe. The trouble is you're actually obvious looking down and you're not getting any information. And so you're walking in this way that's signifying someone who's traumatized or someone who's anxious. So I say walk normally, look around. And again, send those normalized signals through the nervous system.
Bring more sensory information in rather than hide.
Yes. And look, I'm going to take it a little step further. You may want to edit this one out. But in psychology, when someone is looking down, we call this the shame response. And so if you're walking around in the shame response, you're a target. And perpetrators can recognize the shame response.
I've read a story on that where just purely from photos, perpetrators were able to go out and select who they would target, so to speak. And there was a correlation between those photos that they chose who had actually been victims, and the ones that hadn't been chosen, who were not victims. And obviously it's not 100% by any means, but there was a correlation that was strong enough.
Yep. In which case, can't hurt to walk normally and to look around and to come out of that shame response. So I know that's a tangent. We're talking about pain today, not trauma.
But it's just fascinating to see how, I imagine everyone can relate how much pain there is with this immobilization. I think all of us at some level, have stopped doing, something from an activity point of view or post-injury. Yeah. And we do it so naturally. I mean, it's actually... It's just so natural to have an injury and for that injury to turn into chronic pain because we're designed to do it in that way. And we're kind of saying we've got to relearn how to live with chronic pain in a brand new way, one that's moves away from fear, more towards acceptance or holding that space to find a more enriching life.
Yes.
As you have with being able to now kayak and obviously even if you can't go out and kayak with the hard body kayak, you're looking for alternatives. It doesn't mean that you can't. And so there are limitations, but you can still, squeeze the juice out of life as much as you can with this approach.
Yes. And one approach we use to help people shift in this way is a values approach. And I know, Nesh, you're very big on values. And so often we can look at the activities and say, well, what are the values? Can we get those values from some other activities? It's a lovely way to do that. We've got time. I could tell a quick story on this.
Yeah,
okay.
One more story.
All right. So I was working in the pain management unit, and I had a gentleman come in, and he's in a wheelchair. And this is from diabetes. And his wife brought him. He did not want to come in, and he certainly didn't want to talk to the psychologist. That was me.
Sounds like a psychologist I know who had pain shooting down his left arm and didn't want to go to the doctor.
Yeah, thank you. So this gentleman, he was not keen. And I asked him, I said, well, obviously you can't do the things you used to do. Now, what did you used to like to do the most? And he said fishing. I said, fishing, pretty hard in a wheelchair. So, well, tell me, now we're looking at values. What about fishing did you enjoy the most? And he said, the solitude. And the penny dropped. And that is, as soon as this gentleman, his diabetes made him unable to walk around, his wife quit her job and cared for him 24/7. These two are about to strangle each other. Now, that was the big problem here. And so, again, what we worked on was, okay, solitude is important to him. Social life was important to his wife, and they both lost them. And so we just did some work around this, put her in contact with Carers ACT, a wonderful organization, set him up at home with a mobile phone and a workbench where he could spend some time alone doing things he enjoyed, and his wife could go out and be social again. And life got so much better for both of them. And that was looking at pain or disability with a values lens. And it's such a powerful way to do it. And again, I'm giving Nesh another plug here. I know, Nesh, you use values work a lot. And that's in chronic pain, that's one application. So what is it about the activity you liked? How else can we get that value serviced?
And it allows for that downregulation to occur, so there's less sensory information coming in of a threatening nature, and therefore more capable and able to go out and start moving more again, and off we go. It's beautiful. It's beautiful.
Yeah.
Randolph, how can people get in contact with you? It's been an absolute pleasure, but I think a lot of people want to contact and find out more about not only pain but your services. How can they get in contact?
Look, I'm a psychologist in private practice. My practice is called Top Psychology because I like spinning tops. Yeah, I know. It's a values thing. It does take a while to get an appointment with me. I have another psychologist I work with. I also give talks reasonably often in the community. So if you search, Randolph Psychologist in Canberra, there's only one of me.
Perfect.
I have a very out-of-date website, but you'll still find me.
Don't imagine there aren't any aliases out there talking on your behalf.
Other than that, if you're struggling, I do recommend, seek help, seek assistance. And again, someone like Nesh, wonderful practice here, lots of great psychologists, get help. And again, get your life back to normal as much as you can.
Absolutely. And nice plug for me as well there, Randolph. Thank you. It's been an absolute pleasure hearing from you and particularly in this pain area. I think you're an absolute expert, and that's why I send a lot of my pain clients across to you. I know they are very, very fortunate when they're able to be treated by a clinician like yourself. So thanks for coming over to have a bit of a chat on this episode, and I'm sure we'll get you back at some point.
Thank you, Nesh. Thanks for having me, mate.
Thanks, Randolph.
Hope you enjoyed this episode of the podcast. If you haven't already done so, please subscribe and you'll see the next episode pop up in your player.